Welcome, you incredibly curious minds, to another deep dive. Today we're taking a vital shortcut into, well, a pretty dense but absolutely critical area of nursing education, chronic neurological problems. We're talking everything from, the common headache to complex seizure disorders and a whole range of challenging degenerative conditions like multiple sclerosis and Parkinson's disease.
That's right. And our mission today is really to distill the core knowledge from a cornerstone text for nursing students, Lewis's Medical Surgical Nursing.
Yeah.
Think of this as your essential guide. We want to help you navigate the pathophysiology, the risk factors, clinical signs, diagnostic tests, and most importantly, the nursing management for these conditions. We're aiming for those aha moments that really stick, ready for both your exams and, crucially, real-world patient care.
Exactly. So we'll be guiding you step by step, focusing on what you need to assess, what interventions are critical, and importantly, how to educate your patients. This won't be like listening to a textbook. We want practical, actionable insights. So let's jump right in. Let's start with something we pretty much all experience, headaches. But the textbook, Lewis's, reveals there's a lot more to them than just, a dull ache. From a nursing perspective, what's the fundamental way we classify headaches, and why does that distinction matter so much?
That's a really crucial starting point. Headaches are broadly classified as either primary or secondary. Primary headaches, think migraines, they aren't caused by another underlying medical problem, they are the problem itself. Secondary headaches, though, are symptoms. They're pointing to an underlying condition, maybe a sinus infection, could be a head injury, or even something more serious like a brain tumor. And understanding this difference is just paramount because it immediately guides our assessment. It tells us, do we need to dig deeper? Do we need to find a root cause?
Okay, yeah, that makes sense. So let's unpack the big three primary headaches nurses often see: tension type, migraine, and cluster. Lewis's has a great comparison table. How do we tell them apart clinically?
Yeah, that comparison is super helpful. Okay, imagine a patient comes in describing their pain. For a tension-type headache, or TTH, they'll often say it's bilateral, both sides. Feels like a tight band squeezing their head, or maybe a constant dull pressure. The key differentiator, usually mild to moderate pain, and crucially, no nausea or vomiting, and activity doesn't make it worse. Stress is a really common trigger here.
Okay, like the everyday stress headache.
Pretty much. Now, a migraine headache, that's typically unilateral, one side of the head, and it's often throbbing, pulsating, maybe feels like it's in sync with their pulse. The pain is usually moderate to severe, and unlike TTH, it gets significantly worse with movement. And about a quarter of people with migraines get an aura beforehand.
An aura, what's that exactly?
It's a sort of warning signal. Reversible neurological symptoms, often visual stuff like flashing lights, zigzag lines, maybe blind spots. Could also be sensory, like tingling. And with the migraine itself, nausea, vomiting, photophobia sensitivity to light, and phonophobia sensitivity to sound are really common. Genetics, hormones, big risk factors.
Got it. Throbbing, one-sided, maybe an aura, sensitive to light and sound. And the third one, cluster headaches.
Cluster headaches. These are often described as the most severe primary headache, just excruciating. It's a sharp, stabbing pain, usually focused intensely around one eye. What's really unique here are the associated autonomic symptoms on that same side.
Autonomic, like involuntary thing.
Exactly. Involuntary body responses. Think a watery eye, maybe facial flushing or even paleness, nasal congestion. Sometimes the people on that side get smaller. That's meiosis. And they happen in clusters, periods of weeks or months with frequent attacks, often waking the person up at night. They seem to be more common in men and people who smoke.
Wow, that sounds incredibly intense. So differentiating is key. When a patient presents with a headache, what are the crucial diagnostic steps for us as nurses? What info do we need first?
A really thorough history and a good neurologic assessment are paramount. Absolutely number one. For most tension-type headaches, the diagnosis is mainly clinical, based on how they describe it. For migraines, again, that detailed history is vital. There isn't one specific lab or imaging test to confirm it, unless, we suspect a secondary cause based on atypical features. A headache diary can be incredibly helpful. Patients track patterns, triggers, what treatments work. It's useful for all types, but especially migraines and cluster headaches.
And imaging, like CT or MRI.
Yeah, imaging like CT or MRI is mostly used to rule out those potentially dangerous secondary causes. We'd order it if there are concerning red flag symptoms like a sudden explosive headache, a stiff neck, confusion, neurological deficits, things that make you worry about an aneurysm or a tumor.
Okay, that makes sense. Rule out the scary stuff first. Once we have a better idea of the type, what about management? Interprofessional care, nursing strategies. I know it involves both non-drug and drug approaches.
Absolutely. It's definitely a tailored approach. For non-pharmacologic stuff, think lifestyle changes, right? Biofeedback, cognitive behavioral therapy, relaxation techniques, optimizing sleep. These are all crucial, especially for preventing TTH and migraines. They help patients manage their triggers and responses.
And the drug therapies.
So, for drug therapy, for tension type, usually over-the-counter analgesics like NSAIDs, acetaminophen, maybe combined with caffeine or a muscle relaxant. For chronic TTH, sometimes trace cyclic antidepressants or anti-seizure meds are used preventively. For migraine, mild ones might respond to NSAIDs or caffeine combos. But for moderate to severe attacks, triptans like sumatriptan are often the first choice.
Triptans, right. I remember there's a big warning with those.
Yes, absolutely. Critical drug alert here. Triptans cause vasoconstriction. They narrow blood vessels. This means they are contraindicated, absolutely should not be used in patients with heart disease, a history of stroke, or uncontrolled high blood pressure. It could be dangerous. Other options exist, like CGRP antagonists. And for prevention, we use things like beta blockers, certain anti-seizure drugs, Botox injections, even those CGRP antagonists again.
Okay, crucial alert on triptans. And for cluster headaches, how do you treat that intense pain?
For cluster headache, acute treatment often involves triptans too, but usually given nasally or by subcutaneous injection for really rapid action because the pain is so severe. And interestingly, high flow 100% oxygen through a non-rebreather mask for about 20 minutes can be remarkably effective. It seems to help through vasoconstriction as well. For prevention, high-dose verapamil is a common choice, but it needs careful cardiac monitoring because it's a calcium channel blocker.
You mentioned medication, and there's this kind of counterintuitive thing called medication overuse headache. Can you explain that? It sounds tricky.
It is tricky, and it's a critical concept for nurses. MOH happens when someone frequently uses headache meds, even simple over-the-counter ones like ibuprofen or acetaminophen, or prescription meds like triptans. And that overuse paradoxically causes new headaches or makes their existing ones worse. They get caught in this vicious cycle. Headache, take med, temporary relief, rebound headache, take more med. Treatment involves carefully stopping or withdrawing the overused medication and finding alternative therapies. It requires a lot of patient education and support.
Right. So from a nursing perspective, wrapping up headaches, what are our absolute priorities?
A detailed assessment is always key: location, pain type, onset, frequency, duration, triggers. Really encourage those headache diaries. Our goals are pretty clear: reduce their pain, help the patient understand their specific triggers and treatments, promote positive coping strategies, and ultimately improve their quality of life. And I have to reiterate this vital safety alert. If a patient comes in with a severe headache, PLUS, a stiff neck, sudden vomiting, confusion, weakness, double vision, maybe a rash, or they're hard to wake up, that needs immediate emergent evaluation. Those are red flags for potentially life-threatening stuff like meningitis or brain bleed.
So for patient teaching, what practical advice are we giving, like day-to-day stuff?
We really emphasize trigger avoidance. Common ones are certain foods, aged cheese, MSG, nitrates in processed meats, alcohol, fatigue, skipping meals, stress. It varies person to person. It's crucial they understand their medications, the purpose, dosage, side effects, and how to use specific devices like a triptan nasal spray or injector pen. We also teach stress management techniques, talk about regular exercise, the importance of adequate sleep, and crucially, when to call their provider if headaches change, get worse, or treatments aren't working.
Okay, great summary on headaches. Now let's shift from persistent pain to those sudden, unpredictable electrical storms in the brain. Seizures. This is something every nursing student needs a solid grasp on, especially the emergency side. What's fundamentally happening during a seizure?
Right. So at its core, a seizure is a sudden, abnormal, excessive electrical discharge from neurons in the brain. Think of it like a temporary electrical short circuit. This surge leads to involuntary movements, weird sensory experiences, maybe changes in behavior, or altered consciousness. Now, when someone has recurring seizures that aren't provoked by something specific and temporary, typically two or more that happen more than 24 hours apart, that's when we diagnose epilepsy. That distinction matters. A single seizure due to, say, a high fever or a sudden drop in blood sugar isn't automatically epilepsy.
Okay, so epilepsy is the condition of recurring seizures. What actually causes these electrical bursts?
For many people with epilepsy, honestly, the exact cause is unknown, what we call idiopathic. But we think it often involves a group of abnormal neurons that just become hyperexcitable. This might be due to an imbalance between excitatory neurotransmitters, the ones that tell neurons to fire, and inhibitory ones, the ones that tell them to stop. There's also a pretty significant genetic link. Genetic factors might play a role in up to 70% of cases. Then there are known causes, things like stroke, brain tumors, brain infections like meningitis or encephalitis, traumatic brain injury, or even acute metabolic problems like severe electrolyte imbalances.
The classification of seizures used to seem really complicated. Can you simplify the main types nurses need to be able to recognize quickly?
Absolutely. The current classification from the International League Against Epilepsy really focuses on where the seizure starts in the brain. So, broadly, generalized onset seizures. These start over wide areas of both sides of the brain simultaneously. Consciousness is usually impaired from the outset. The most common motor type here is the tonic-clonic seizure, what people used to call grand mal.
That's the one most people picture, right?
Exactly. The person loses consciousness, their body stiffens up, that's the tonic phase, and then their extremities start jerking rhythmically, that's the clonic phase. You might see cyanosis, which is bluish skin from lack of oxygen, maybe excessive salivation, sometimes tongue or cheek biting, and maybe incontinence. Another generalized type, but non-motor, is the absence seizure, much more common in children.
Absence. Like they're just spacing out.
Precisely. It looks like a brief staring spell, like daydreaming. They suddenly stop activity, might have a blank look, maybe some subtle movements like eyelid fluttering. It usually lasts less than 20 seconds, often less than 10. They recover abruptly and often aren't even aware it happened. Sometimes they're missed or misdiagnosed as daydreaming or ADHD.
Okay, so generalized involves both sides of the brain. What about the other main category?
That's focal onset seizures. These start in just one hemisphere of the brain, in a specific localized area or network. The symptoms totally depend on where in the brain that seizure activity is happening, so they can be incredibly varied. We further divide these based on awareness. In focal awareness seizures, the person stays conscious and alert. They know what's happening. But they experience unusual feelings or sensations, maybe sudden joy or sadness, odd smells or tastes, tingling, or maybe just twitching in one hand or their face.
So they're aware, but something unusual is happening. What about the other focal type?
That's focal impaired awareness seizures. Here, their consciousness or awareness is altered or lost. They might enter a dreamlike state, their eyes are usually open, and they might perform repetitive, seemingly purposeful movements called automatisms, like lip smacking, picking at clothes, fumbling. But they can't interact normally, they won't respond to you, and critically, they won't remember the event afterwards. These used to be called complex partial seizures.
Okay, that distinction between awareness and impaired awareness seems really important for observation. What about the phases of a seizure? Does every seizure follow a pattern?
Good question. There are potentially 4 phases, but not every patient experiences every single one, and not for every seizure type. First is the prodromal phase. These are subtle signs or symptoms that can happen hours or even days before a seizure, maybe mood changes, sleep issues, feeling irritable. Then some people experience an oral phase. This is a sensory warning that happens right before the seizure really takes hold. It's actually considered part of the seizure itself. It's usually consistent for that person, maybe a specific smell, a flash of light, a feeling of déjà vu, or sudden anxiety.
So the aura is part of the seizure. Then what?
Then comes the ictal phase. This is the main event from the very first symptom to the end of the seizure activity itself. This is the part we observe most closely, how long it lasts, what happens during it, and finally, the postictal phase. This is the recovery period after the seizure. The patient might be really tired, confused, disoriented, have muscle soreness, maybe a headache. They might sleep for hours. Memory, the ictal phase is often gone, especially after generalized or focal impaired awareness seizures. The duration of this phase varies a lot too.
Understanding those phases helps with assessment. Now, what about complications? You mentioned status epilepticus earlier. Sounds like a major emergency.
It absolutely is. Status epilepticus, or SE, is a critical neurologic emergency. It's defined as any seizure lasting longer than 5 minutes, or when seizures happen back-to-back without the person regaining full consciousness in between. Basically, the brain is stuck in a seizure state. It's using up massive amounts of energy and oxygen, far more than the body can supply. This can lead to permanent brain damage if it's not stopped quickly. Convulsive SE, the kind with prolonged muscle contractions, is particularly dangerous because it can cause respiratory failure, low oxygen levels, heart rhythm problems, severe muscle breakdown, and acidosis. Rapid intervention is absolutely vital.
5 minutes. That's the key time frame to remember. Any other major complications?
Yes, unfortunately, there's sudden unexpected death in epilepsy, or SUDP. It's rare, but it's a devastating risk, most often associated with uncontrolled tonic-clonic seizures, especially those happening during sleep. The exact cause isn't fully understood, and we can't forget the psychosocial complications. Living with epilepsy can lead to depression, anxiety, social stigma, difficulties with employment or driving. It impacts every aspect of life.
Definitely a condition with wide-ranging impacts. How do we diagnose seizure disorder? And what's the interprofessional approach, especially in an emergency?
Diagnosis relies heavily on a comprehensive history and a detailed description of the seizure events. Often, getting information from witnesses is crucial because the patient may not remember. An EEG, that's an electroencephalogram, recording brain waves is often used. It can show abnormal electrical activity patterns that are characteristic of epilepsy. But a normal EEG between seizures doesn't rule it out. Sometimes longer monitoring, like video EEG, is needed. For any new onset seizure, imaging like CT or MRI is essential to rule out structural causes, tumors, stroke, vascular malformations.
Okay, and in an emergency, that's someone having a clonic seizure right now.
Okay, emergency management. As a nurse, your immediate priorities are: 1. Ensure a pattern airway. Gently turn the patient onto their side to help drainage of secretions and prevent aspiration. Don't force anything. 2. Protect them from injury. Pad their head if possible. Clear the area around them. Loosen any tight clothing, especially around the neck. But critically, do not restrain them. Restraining can cause injury. And do not force anything into their mouth. No tongue blades, no fingers. That's an old myth and dangerous. 3. Establish 4 access if possible for medication administration. 4. Anticipate giving rapid-acting anti-seizure drugs, usually benzodiazepines like obilorazepam or midazolam, to stop the seizure activity quickly. Observe and record everything.
Got it. Airway safety, no restraints, no objects in mouth. Anticipate benzos. What about long-term treatment?
Long-term, drug therapy with anti-seizure drugs is the main treatment for most people with epilepsy. The goal is to prevent seizures completely, or at least reduce their frequency and severity, with the minimum possible side effects. Therapy usually starts with a single drug, chosen based on the seizure type and patient factors. Common ones include drugs like phenytoin, carbamazepine, Devolprox, lamotrigine, levetiracetam. There are many options. Dosage is carefully adjusted. If the first drug doesn't work or causes bad side effects, another might be tried, or sometimes a combination is needed. And here's another huge drug alert. Abrupt withdrawal of these medications after long-term use can trigger seizures, even status epilepticus. Adherence is absolutely critical. Patients must understand they can't just stop taking them.
Okay, adherence is vital. What about side effects?
Side effects often involve the central nervous system, things like drowsiness, dizziness, problems with coordination or balance, ataxia, sometimes vision changes. We need to monitor for these and educate patients. Older adults can be more sensitive to side effects and may need lower doses or different drug choices due to potential interactions with other meds.
So balancing seizure control with side effects is key. What's our nursing role in managing seizure disorder both acutely and long-term in the community?
You've hit it. It's that balance. First, during any active seizure, remember that safety alert. Maintain airway, protect head, turn to side, loosen clothing. Do not restrain, do not put objects in mouth. That's paramount. In acute care, besides immediate safety, meticulous observation and detailed recording are critical. Note exactly what happened before the seizure, prodromal, how long each phase lasted, what the motor movements look like, which body parts are symmetrical, any eye deviation, breathing changes, autonomic signs like sweating or flushing. After the seizure, in the post-ictal phase, assess their airway again, make sure they're breathing okay, reposition them for comfort and safety, suction if needed, maybe provide oxygen, stay with them, reassure them, and reorient them as they wake up.
And what about once they're stable, or for managing epilepsy in the community?
Yeah.
Ambulatory care.
Right. For ambulatory care, the focus shifts to preventing recurrence and promoting self-management. Patient and caregiver education is huge. We need to emphasize medication adherence, why it's important. Using pill boxes, setting reminders, teach them to report side effects to their provider, help them identify and avoid personal seizure triggers, which might include things like excessive alcohol, severe fatigue, lack of sleep, sometimes even flashing lights. Encourage keeping a seizure diary to track patterns, and crucially, teach them when to seek emergency care. Definitely if a seizure lasts longer than 5 minutes, if they have back-to-back seizures, if they get injured during a seizure, or if it's their very first seizure ever. We also need to address the psychosocial aspects, connecting them to support groups like the Epilepsy Foundation, discussing driving regulations, which vary by state, advising on wearing medical alert identification.
That's a really comprehensive role for nurses. Okay, let's touch briefly on another chronic neurologic condition mentioned in the chapter, restless leg syndrome, or RLS. Many people joke about it, but it can be quite disruptive, right?
Oh, absolutely. RLS is no joke for those who have it. It's a common sensory and movement disorder. It's characterized by these really unpleasant sensations in the legs, sometimes arms too often described as crawling, creeping, itching, tingling, pulling, paired with an almost overwhelming urge to move the limbs. The key features are that these symptoms worsen during rest or inactivity, like when sitting or lying down, and they're temporarily relieved by movement, like walking or stretching. It's typically worse in the evening or at night, which is why it severely disrupts sleep and causes significant daytime fatigue.
What causes that creepy crawly feeling?
The exact cause isn't fully known, but it's strongly believed to involve dysfunction in the brain's dopamine pathways in the basal ganglia, similar area involved in Parkinson's, interestingly. Iron deficiency can also play a significant role or worsen symptoms, and there's often a strong genetic component. Diagnosis is mainly clinical, based on specific criteria. Management involves lifestyle changes, first reducing caffeine, alcohol, tobacco, establishing regular sleep habits, moderate exercise, maybe leg massage or warm baths. Avoiding certain meds like some antihistamines can help. If that's not enough, drug therapy might include dopamine agonists like ropinirole or pramipexole, often used in PD2, or certain anti-seizure drugs like gabapentin. Checking and treating iron deficiency is also important.
Okay, good overview of RLS. Now let's move into that particularly challenging category. Degenerative neurologic disorders. What's the common thread here?
This group includes conditions like multiple sclerosis, MS, Parkinson disease, PD, myasthenia gravis, MG, amyotrophic lateral sclerosis, ALS, and Huntington disease, HD. The common thread is progressive, relentless nerve damage or dysfunction that worsens over time. This damage often affects critical functions: vision, balance, coordination, muscle strength, speech, swallowing, sometimes breathing and heart function. And what makes them so particularly challenging for patients, families, and healthcare providers is that for most of these, there's currently no cure. Treatment focuses intensely on managing symptoms, slowing progression where possible, maintaining the best possible function, and preserving quality of life. Many also have a genetic basis, adding another layer of complexity.
Let's start with multiple sclerosis. What's the underlying process? You said it's autoimmune.
That's right. MS is a chronic, often unpredictable, progressive autoimmune disease attacking the central nervous system, the brain, and spinal cord. The body's own immune system mistakenly attacks the myelin sheath. Myelin is the fatty, insulating layer that covers nerve fibers, kind of like the insulation on an electrical wire. It helps nerve impulses travel quickly and efficiently. In MS, this attack causes inflammation and damage to the myelin called demyelination. Initially, the body might try to repair it, leading to periods of remission. But as the disease progresses, the inflammation continues, the myelin gets destroyed and can't regenerate properly, and eventually, the underlying nerve fiber, the axon itself, gets damaged or destroyed. This leads to permanent nerve function loss and the formation of scar tissue, or hard plaque sclerosis means hardening scattered throughout the CNS.
So multiple sclerosis literally means multiple hardened areas or scars. And because these plaques can form anywhere in the brain or spinal cord, the symptoms must be incredibly varied.
Exactly. The symptoms depend entirely on where the demyelination and nerve damage occur. That's why MS is so heterogeneous, it looks different in different people. Onset is often slow, gradual. Common early symptoms might be visual disturbances, blurred vision, double vision, diplopia, maybe reddish-green color distortion, or even temporary blindness in one eye, optic neuritis. Other common manifestations include muscle weakness, problems with coordination and balance, ataxia, numbness and tingling, paresthesias, often in the limbs. Some patients experience Lermit's sign, that's a transient electric shock-like sensation shooting down the spine or into the limbs when they flex their neck. Severe fatigue, out of proportion to activity, is also a huge issue for many.
What about other functions like bladder, bowel, thinking?
Yes, those are frequently affected too. Bladder problems are very common. A spastic bladder leads to urinary urgency, frequency, dribbling, or incontinence. A flaccid bladder causes urinary retention because the bladder muscle doesn't contract properly. Constipation is also common due to immobility and effects on bowel innervation. Cognitive impairment affects about half of people with MS. This isn't usually severe dementia, but more subtle issues with processing speed, short-term memory, attention, planning, multitasking. Emotional changes are also common: depression, anxiety, sometimes inappropriate euphoria, or mood swings. The unpredictability of the disease course itself is a major source of stress.
It sounds incredibly challenging to live with. How is MS diagnosed and what can we do for treatment given there's no cure?
Diagnosis is based on a combination of factors: the patient's history, their clinical signs and symptoms, findings on an MRI of the brain and spinal cord, looking for those characteristic plaques or lesions in specific locations, and sometimes analysis of cerebrospinal fluid, CSF, obtained via lumbar puncture, which might show increased levels of certain antibodies. The diagnostic criteria essentially require evidence of damage in at least two separate areas of the CNS, evidence that the damage occurred at different points in time, and ruling out other possible diagnoses that could mimic MS group. As for treatment, since there's no cure, the goals are to modify the disease course, treat acute flare-ups, exacerbations, and manage symptoms. Disease-modifying drugs, DMDs, are the mainstay for slowing progression and reducing relapse frequency. These include injectable interferons, oral medications, and infused monoclonal antibodies. They generally work by suppressing or modulating the immune system. There's a drug alert for beta interferon specifically. Nurses need to assess for depression and suicidal thoughts, as these can be side effects. Also, warn patients about common flu-like symptoms after injection. Acute exacerbations are usually treated with high-dose IV corticosteroids like methylprednisolone to reduce inflammation quickly.
And managing the day-to-day symptoms.
Symptom management is huge. There are medications to help with muscle spasticity, fatigue, neuropathic pain, bladder dysfunction, like anticholinergics for spastic bladder or cholinergics for flaccid bladder, and even drugs specifically approved to improve walking speed. Other therapies are also vital. Physical therapy is crucial for maintaining strength, flexibility, balance, and managing spasticity. Occupational therapy helps with adapting daily activities. Speech therapy if swallowing or speech is affected. Water exercise, as mentioned in Limises, can be particularly beneficial because the water's buoyancy supports weak limbs and helps cool the body, as heat often worsens MS symptoms.
So for nursing management of MS, what are our key priorities? How do we empower patients?
It's really about empowering the patient to manage this chronic, unpredictable condition. We help them identify and manage triggers that might cause exacerbations. Common ones include infections, like UTIs or upper respiratory infections, trauma, significant stress, fatigue, and exposure to heat or extreme cold. Teach strategies to avoid or minimize these. During an acute exacerbation, especially if they're hospitalized or less mobile, preventing complications of immobility is key. Preventing pressure injuries, respiratory infections, UTIs, constipation. We provide extensive education on bladder and bowel management, maybe teaching self-catheterization if they have retention, encouraging adequate fluid intake and a high-fiber diet for constipation. Psychosocial support is absolutely critical. Coping with the uncertainty, the potential for disability, the impact on relationships and work, it's immense. We need to assess their coping mechanisms, support systems, and connect them to resources like the National Multiple Sclerosis Society for information and peer support.
Empowering them to live as fully as possible. Okay, let's pivot now to Parkinson's disease, PD, another major neurodegenerative challenge. What defines PD and what's going wrong in the brain?
Parkinson's disease is a chronic, progressive neurodegenerative disorder primarily affecting movement. It's defined by four cardinal manifestations, often remembered by the acronym TRAP. Tremor, usually at rest. Rigidity, increased muscle tone. Akinesia, or more accurately, bradykinesia, slowness of movement. And postural instability, impaired balance and coordination. The underlying pathology involves the degeneration and death of dopamine-producing neurons in a specific area of the midbrain called the substantia nigra. Dopamine is a crucial neurotransmitter for smooth, controlled movement. Its loss disrupts the delicate balance between dopamine and another neurotransmitter, acetylcholine, in the basal ganglia, which is the brain region controlling movement. This imbalance leads to the characteristic motor symptoms. Another pathologic hallmark found in the brains of people with PD is the presence of clumps of abnormal protein called Lewy bodies within the remaining neurons. Their exact role is still being researched, but they're characteristic of the disease.
Okay, so TRAP, tremor, rigidity, akinesia, bradykinesia, postural instability, all stemming from that dopamine deficit. Can you elaborate a bit on each of those?
Sure. The tremor is often the first sign people notice. It's typically a pill-rolling tremor, looks like they're rolling something between their thumb and forefinger. It's usually most prominent when the limb is at rest and often lessens or disappears during purposeful movement or sleep. It often starts in one hand or foot. Rigidity is that increased resistance to passive movement when you try to move their limb. It can feel like stiffness or inflexibility. Sometimes it has a jerky, cogwheel quality like intermittent catches as you move the limb. This rigidity contributes to muscle soreness and pain. Bradykinesia means slowness of movement. This is often the most disabling symptom. It affects not just initiating movement, but also executing it smoothly and quickly. This leads to difficulty with everyday tasks, getting dressed, cutting food. It also affects automatic movements, leading to that characteristic masked face, lack of facial expression. Decreased blinking, reduced arm swing when walking, soft, monotonous speech, and sometimes drooling. And that slowness contributes to the typical shuffling gait called festination, where they take small, quick steps, often leaning forward.
And the P in TRAPI, postural instability.
Right. Postural instability usually develops later in the disease. Patients have trouble maintaining balance and making postural adjustments. They might sway when turning, have difficulty stopping once they start walking, and are prone to falls. We often use the pull test, a gentle pull backwards on their shoulders, to assess their ability to recover their balance. It's also really important to remember the non-motor symptoms, things like depression, anxiety, apathy, fatigue, pain, constipation, sleep problems like REM sleep behavior disorder where they act out dreams, and eventually cognitive changes or dementia are very common and significantly impact quality of life.
It sounds like it affects almost every aspect of function. Given its progressive nature, what are the key complications nurses need to monitor for?
Dysphagia, difficulty swallowing, is a major concern as the disease progresses. This can lead to malnutrition, dehydration, and aspiration pneumonia, which is a common cause of death. Increasing weakness and immobility lead to risks like constipation, contractures, and pressure injuries. Orthostatic hypotension, a drop in blood pressure upon standing, is common due to autonomic dysfunction and medications, and it significantly increases the risk of falls and injury. As the disease progresses and medication effects change, patients can develop dyskinesias. These are spontaneous, involuntary writhing or flowing movements, often as a side effect of long-term levodopa use. And neuropsychiatric problems, including depression, anxiety, psychosis, hallucinations, delusions, and eventually dementia, become more common and challenging to manage. Dementia in PD is associated with increased mortality.
Such serious complications.
Yeah.
How is PD diagnosed, especially since there's no single test?
Yes.
And what treatments are available?
Diagnosis is primarily clinical. There's no definitive blood test or brain scan. It relies on the patient's history. A thorough neurological exam finding at least 2 of the 4 cardinal TRT signs, especially if tremor or bradykinesia is present, and, often quite significantly, a positive response to anti-Parkinsonian medications. If someone's symptoms improve markedly when they start taking dopamine-related drugs, it strongly supports a PD diagnosis. An MRI might be done, but usually it's normal in PD, and mainly serves to rule out other conditions that could cause similar symptoms, like stroke or normal pressure hydrocephalus.
So the response to medication is almost diagnostic. What are the main drug therapies?
Drug therapy aims to correct the imbalance of neurotransmitters, primarily by enhancing dopamine levels or activity, or by blocking the effects of acetylcholine. The cornerstone drug is levodopa, often combined with carbidopa, as Sinemet. Levodopa is a precursor to dopamine that can cross the blood-brain barrier. Dopamine itself cannot. Carbidopa prevents levodopa from being broken down in the periphery, allowing more to get to the brain and reducing side effects like nausea. Here's a key drug alert for levodopa-carbidopa. While it's highly effective, especially early on, long-term use often leads to fluctuations in response, predictable wearing-off periods before the next dose, or unpredictable on-off episodes where motor function suddenly switches between good mobility and severe immobility or dyskinesia. Nurses need to monitor for these, as well as dyskinesias, mental changes like confusion or hallucinations, and palpitations. Other drug classes include dopamine receptor agonists like pramipexole, ropinirole, which directly stimulate dopamine receptors. They might be used first, especially in younger patients, or later as an adjunct to levodopa. There's a specific alert for one agonist, apomorphine, used for rescue therapy during off episodes, regarding severe nausea vomiting risks. Anticholinergics, like bensterpine, block acetylcholine and are mainly helpful for tremor and rigidity, but have side effects like dry mouth, constipation, confusion, especially in older adults. And there are other drugs like MAOB inhibitors and COMT inhibitors that help enhance dopamine levels or prolong levodopa's action.
What about when drugs aren't enough or cause too many problems? Is surgery an option?
Yes. Surgical therapy is considered for patients whose symptoms are not adequately controlled by medication or who experience severe motor fluctuations or disabling dyskinesias. The most common procedure now is deep brain stimulation, DBS. This involves surgically implanting electrodes into specific target areas in the brain, like the subthalamic nucleus or globus pallidus. These electrodes are connected by wires under the skin to a pulse generator, like a pacemaker, implanted in the chest. The generator sends continuous electrical impulses to the target areas, which helps regulate abnormal brain activity and improve motor symptoms like tremor, rigidity, bradykinesia, and often reduces the need for medication and lessens dyskinesias. It doesn't stop disease progression, but it can significantly improve quality of life for selected patients. Older procedures involved ablation, creating targeted lesions to destroy overactive brain areas, but DBS is generally preferred now as it's reversible and adjustable.
DBS sounds quite sophisticated. From a nursing perspective,
How do we help patients with PD maintain function, safety, and quality of life day to day?
Our focus is really holistic, maintaining good general health, maximizing independence for as long as possible, and preventing complications. Exercise is absolutely crucial. Regular exercise helps limit muscle atrophy, contractures, and constipation. It improves strength, flexibility, balance, and even mood. Physical therapy is vital for designing tailored exercise programs, working on gait training, balance, and transfers. Speech therapy helps with voice volume and swallowing issues. Occupational therapy helps adapt tasks and environments for safety and independence. Safety in the home is paramount due to the high fall risk. We advise removing throw rugs, reducing clutter, ensuring good lighting, suggest adaptations like raised toilet seats, grab bars in the bathroom, using chairs with arms. Clothing adaptations like using Velcro closures instead of buttons can make dressing easier. Nutrition needs careful attention. A well-balanced diet with adequate fiber and fluids helps prevent constipation. Because dysphagia is common, food should be easily chewed and swallowed. Sometimes smaller, more frequent meals, like 6 small meals, are better tolerated than 3 large ones. There's an important interaction with levodopa. Protein can compete with its absorption. So some experts suggest limiting protein intake during the day and having the main protein meal in the evening, although this needs careful dietary planning to ensure adequate nutrition. Always assess swallowing ability before meals and observe for signs of aspiration. And importantly, psychosocial support. Living with PD takes a toll on both the patient and their family. We need to assess for and address depression, anxiety, sleep disturbances, and caregiver burden. Connecting them to support groups like those run by the American Parkinson Disease Association or the Parkinson's Foundation provides invaluable peer support and resources.
Such a multifaceted approach needed. Okay, we've covered a lot. Let's quickly touch on a few other significant degenerative conditions mentioned in Lewis's, starting with myasthenia gravis, MG. This is another autoimmune one affecting muscles, but differently than MS, right?
Correct. Myasthenia gravis is also autoimmune, but it specifically targets the neuromuscular junction, the point where nerve cells communicate with muscle cells. In MG, antibodies produced by the immune system attack and destroy or block acetylcholine AC8 receptors on the muscle cell surface. Acetylcholine is the neurotransmitter released by nerves to tell muscles to contract. With fewer functioning AC receptors, the muscle doesn't receive the signal properly, leading to muscle weakness. The thymus gland, located in the chest, is often abnormal in people with MG and seems to play a role in producing these harmful antibodies.
So if the signal isn't getting through properly, what does that look like clinically?
The absolute hallmark of MG is fluctuating weakness of skeletal muscles. Critically, the weakness typically worsens with repetitive muscle use activity and improves with rest. Muscles used frequently are often affected first and most severely. Ocular muscles are involved initially in about 90% of cases, causing drooping eyelids, ictosis, and double vision diplopia. Weakness can also affect facial expression, chewing, swallowing, dysphagia, and speech, dysarthria, often nasal sounding. Limb weakness can occur too, often more proximal, shoulders, hips. A major concern is weakness of respiratory muscles, which can lead to a life-threatening situation called myasthenic crisis.
Myasthenic crisis. That sounds serious.
It is. It's an acute worsening of muscle weakness, often triggered by infection, surgery, stress, or inadequate medication. It can severely impair breathing and swallowing, potentially leading to respiratory insufficiency or aspiration. Patients may require emergency intubation and mechanical ventilation. It's crucial for nurses to recognize this and also to differentiate it from cholinergic crisis. Cholinergic crisis is caused by too much anticholinesterase medication, the drugs used to treat MG. It also causes muscle weakness, but it has distinct additional signs related to overstimulation of the parasympathetic nervous system, things like increased saliva and bronchial secretions, abdominal cramping, diarrhea, sweating, and pupillary constriction, meiosis. Telling them apart is vital because the treatment is opposite. Myasthenic crisis needs more anticholinesterase medication or other therapies like plasmapheresis BIG, while cholinergic crisis requires stopping the anticholinesterase meds and potentially giving an antidote like atropine.
Okay, differentiating those crises is key. How is MG diagnosed and managed?
Diagnosis often involves history and physical exam, looking for that characteristic fatigable weakness. For e.g., having them sustain an upward gaze might reveal increasing proptosis. Specific tests include blood tests for ACEA receptor antibodies, positive in most patients, electrophysiologic tests like single-fiber EMG, which is very sensitive for detecting impaired neuromuscular transmission, and sometimes the edrophonium tensilon test. In this test, a short-acting anticholinesterase drug is given IV. A rapid temporary improvement in muscle strength strongly suggests MG. though tensilin use is less common now due to potential cardiac side effects and availability of antibody tests. Management involves several approaches. Drug therapy. Anticholinesterase drugs like pyridostigmine, mestinon are first line. They don't fix the underlying problem, but improve neuromuscular transmission by making more ACO available at the junction. Corticosteroids like prednisone and other immunosuppressants like azathioprine are used to suppress the autoimmune attack. Newer targeted therapies like monoclonal antibodies are also emerging. Surgical therapy. Thymectomy, the surgical removal of the thymus gland, can lead to significant improvement or even remission in many patients, especially those with thymic hyperplasia or tumor, thymoma. Other therapies. Plasmapheresis, plasma exchange to remove harmful antibodies, and intravenous immunoglobulin, IVIG, can provide rapid, short-term improvement in strength, often used to manage myasthenic crisis or prepare patients for surgery.
And the nursing priorities for MG.
In an acute crisis, obviously maintaining adequate ventilation, managing secretions, and assisting with therapies like plasmapheresis or IVIG are paramount. Correctly identifying whether it's myasthenic or cholinergic crisis is critical. For ongoing care, it's about managing the neurologic deficits and their impact on daily life. We teach patients about their medications, especially timing doses to peak during periods of planned activity or meals. We educate on strategies to conserve energy, planning rest periods. We address nutrition, maybe suggesting softer foods if chewing swallowing is difficult, and ensuring they sit upright during meals to reduce aspiration risk. Patient education about the disease, treatment plan, potential complications like myasthenic crisis, and when to seek help is vital. Connecting them to resources like the Myasthenia Gravis Foundation of America is also important.
Great. Lastly, let's briefly touch on amyotrophic lateral sclerosis, ALS, and Huntington disease, HD. Both devastating, but distinct. Give us the essentials.
Okay, quickly. ALS, often called Lou Gehrig's disease, is a rare, relentlessly progressive neuromuscular disorder. It's marked by the degeneration and loss of motor neurons, the nerve cells controlling voluntary muscles in both the brainstem and spinal cord. This leads to progressive muscle weakness, wasting, atrophy, twitching, fasciculations, and eventually paralysis. It affects muscles involved in moving, speaking, swallowing, and ultimately breathing. What's particularly tragic about ALS is that typically the patient's cognitive function, their thinking, awareness, senses, remains intact, while their body progressively fails them. It's incredibly challenging. There's currently no cure. Medications like riluzole and edaravone may modestly slow decline. Nursing care is hugely important and focuses on managing symptoms. Facilitating communication as speech fails, using assistive devices, reducing aspiration risk with swallowing difficulties, monitoring respiratory function, and supporting ventilation when needed, managing pain and spasticity, preventing complications of immobility, and providing immense emotional and psychosocial support, including compassionate end-of-life care planning.
Profoundly challenging indeed. And Huntington's disease.
Huntington disease, HD, is quite different. It's a genetically transmitted autosomal dominant disorder. That means if one parent has the gene, each child has a 50% chance of inheriting it. It causes a progressive breakdown of nerve cells in specific areas of the brain, particularly the basal ganglia and cerebral cortex. Unlike PD, where there's a dopamine deficit, HD involves a relative excess of dopamine activity due to deficiency of other neurotransmitters like acetylcholine and GABA. This leads to a unique triad of manifestations. 1. Movement disorders. The most characteristic is chorea, those excessive, involuntary, jerky, writhing, dance-like movements affecting the limbs, face, and trunk. As it progresses, movements may become less choreic and more rigid or slow, like Parkinsonism. 2. Cognitive deterioration. Problems with thinking, memory, judgment, attention, planning, progressing eventually to severe dementia. 3. Psychiatric symptoms. Depression, anxiety, irritability, apathy, obsessive-compulsive behaviors, sometimes psychosis. Personality changes are common.
A devastating genetic condition affecting movement, cognition, and mood. What are the nursing priorities for HD?
Since there's no cure and treatments can't stop the progression, care is primarily palliative and supportive. Medications can help manage the chorea, like tetrabenazine or antipsychotics, and psychiatric symptoms, antidepressants, mood stabilizers. Nursing focuses heavily on physical safety due to the involuntary movements and cognitive decline, which increase fall risk. Maintaining adequate nutrition is a huge challenge. The constant choreic movements burn massive amounts of calories, so patients often need a very high-calorie diet, maybe 4,000, 5,000 calories a day, just to maintain weight. Swallowing difficulties, dysphagia also develop, increasing aspiration risk. Providing emotional and psychological support to both the patient and the family is crucial, especially given the genetic implications and the progressive nature of the decline. caregiver burden is immense.
Hmm.
End-of-life discussions, including advance directives, decisions about artificial nutrition and hydration, and palliative care or hospice involvement, are important conversations to have throughout the disease course, respecting the patient's autonomy as long as possible. Connecting families to resources like the Huntington's Disease Society of America is vital.
Wow. That was truly an intensive deep dive into some incredibly complex, yet absolutely critical areas of neurologic nursing. You should now have a much clearer pathway to understanding headache, seizure disorders, RLS, and those really challenging degenerative conditions like MS, PD, MG, ALS, and HD.
You know, what really stands out to me across all these chronic neurologic problems is just the immense importance of holistic nursing care. It goes so far beyond just medications and procedures. It's truly about being an advocate for your patient, providing really comprehensive, tailored education, understanding their specific condition, whether it's the unpredictable nature of MS or the steady decline of PD, and offering that unwavering psychosocial support, not just for the patient, but for their caregivers too, as they navigate these often long and difficult journeys. Each person's experience is unique, and our role as nurses is to optimize their function, manage their symptoms, and support their quality of life every single step of the way. We have to focus on the whole person, their whole experience, not just the disease process.
Absolutely well said. As future nurses, your ability to integrate all these complex pieces, understanding the pathophysiology right down to the neurotransmitter level, but also grasping the huge impact these conditions have on a person's life, their family, their identity, the integration is what will truly define exceptional care. Understanding the why behind the symptoms helps you anticipate needs, but understanding the human experience helps you provide truly compassionate and effective care. Thank you so much for joining us on this deep dive. And from the Last Minute Lecture team, thank you for learning with us.